This is actually a picture of Langerhans himself, who, as you may or may not know, discovered or first described the Langerhans cell. That's just the Berwick granule on the electron microscopy, while he was still a medical student, which is sort of a lesson to all of us. Anyway, so bone Langerhans cell histiocytosis is the commonest single organ in children with LCH. As you heard this morning, that's not true for the neonate, but it is true for most of the childhood population. And to the point that if you look at our Sick Kids series again, so this is children admitted to one big institution, and we do see at least 65% of the children from all of Ontario. So hopefully there's very little bias in what comes to us, because there are some other big centres around. So we tend to be, this may be as close as you can get to a sort of population-based statistic. Anyway, between January 80 and December 98, we had 154 children admitted with Langerhans cell histiocytosis. Of course, as with all statistics on LCH, that's certainly an underestimate, because many children are not diagnosed. We think skin only, maybe even bone only kids. But anyway, when we looked at the bone, 126 of the 154 had a bone LCH, so that was 81% of all LCH has bone disease, and of that, the vast majority are single system bone. So 80% of the patients, of the 80%, had single system bone disease, and when you looked at bone as part of multi-system disease, that was about 20% of the patients. And again, looking at our statistics and comparing them to the German or Austrian group, where they looked at the patients admitted to the early studies, you can see that in fact it's very, very similar, that there's not a lot of difference. So that single bone was present in about 76% or so of patients, and multifocal, this is now just the ones with single system bone, so bone only disease. The vast majority are single bone, 3/4 about, and 1/4 are of multifocal bone. So of the whole group, about 1/4 are multisystem. Of the single system bone, about 1/4 are multifocal bone. So that by far the commonest presentation of LCH in children is with a single bone lesion, and that's the group, of course, that has a very, very good prognosis. So for the most part, LCH in childhood actually does very well. And what sort of bones does this occur in? So as you heard this morning, the skull is the commonest bone. This difference is because we looked at the jaw separately and they didn't. So in actual fact, again, the statistics are very similar between the two studies, that just under a half occur in the skull, then the long bones, the leg bone, jaw bone being next, pelvis, vertebral body and ribs. But I think pretty much, if you think of it this way, it can affect any bone in the body, but usually for whatever reason spares the hands and the feet. And even in the long bones of the arms and legs, it is commoner in the part nearest the body than the part more distant. And again, why do these things happen? Well, we wish we knew. But the hands and feet do tend to be spared from LCH. How does bone present? Well, I think people who have children with bone disease know perfectly well that the usual presentation is you have pain in the bone. It may be worse at night at first. It may occur only at night at first, which is very misleading, and is why a lot of the children are initially diagnosed as growing pains or something like that. But generally speaking, it doesn't just stay only at night if it's missed, but it can occur mainly at night or only at night, and then may or may not be associated with a swelling around the area. And then, of course, the others depend on which bone is involved, and that can be any bone in the body. But I did want to mention these two, because I think when you look at back pain, there are many, many causes of back pain, and obviously you have to do the investigations. But I think when you get this sort of thing, loose teeth that are not obviously the normal childhood tooth loss, or a chronically discharging ear in this day and age of antibiotics, that should raise some sort of alarm in the physician's mind that something else is going on here, that this is not the usual sort of thing you see in childhood. So loose teeth obviously means a jaw mass. The chronically discharging ear is temporal bone and mastoid. And very occasionally, even with single bone, you can get a fever. So this is a CT scan showing you a very typical, the commonest presentation of LCH is a single bone and single lesion. And here you see the sort of hole in the bone, but it's not really a hole, because as you can see, there is a soft tissue component, and that's where all the Langerhans cells are. And the hole in bone, as you heard this morning, is due to the chemicals produced by these cells which break down the bone. And you could see, I don't know how well it projects there, but you can see that this would present with a little mass here on the skull and probably pain, and then you do the x-ray and you find the bone. And here's a little girl, and I have permission, of course, to show these, who presented with what was thought to be infection around the eye, but with swelling around and pain around the eye. And this is a guy with the same thing, but on the other eye, just this large mass with pain. And here's the CT scan showing you that large mass actually pushing back on the eyeball here in this area. Here's another one, which is taken from a book, because this is, I think, is a really good picture. It's a good x-ray showing you the large hole here in the lower jaw with loss of the tooth bud, and here's the CT scan showing you the soft tissue mass on both sides of the hole in the bone. This is a rib LCH lesion, and as you could imagine, this obviously presents with pain. Here it would be in the back. May or may not show some swelling. It might be a hard area to pick that up. And this would, of course, be very difficult for anybody to distinguish from the malignant lesions that can occur in this area as well. I just wanted to just mention this concept, which you heard somewhat about from Dr. Whitlock and Dr. Nanduri this morning, and that's this concept of special site bone as defined by the LCH3 protocol. And the first thing in special site is the site that gives you an increased risk of DI. And as you heard, this is the anterior part of the face, not the vault, which is the commonest area involved. That really doesn't have a very high risk of DI, but the anterior part of the face, so the orbit, the sinuses, the middle ear, the mastoid for sure, the jaw, anything in this anterior part of the face, almost as if you could think of maybe some sort of drainage channel going back to the pituitary gland, which is just behind in the middle. But nobody's ever described such a channel, but it is interesting that the biggest risk is this area. But of course it can occur with other areas. But anyway, so all these bones in sort of the front of the face and the ear are what's associated with DI and are the special site. And this just shows you what Dr. Greuss in Vienna would consider the most significant special site, and that's the chronic mastoid involvement, which he thinks really is an important area of disease and a risk for both DI and CNS disease.